And so I've transitioned to, if you're a right-handed thrower and a right-handed batter, I don't let you throw or hit, because swinging a bat from the right side still puts valgus stress on your elbow. And all it takes is one bad swing.
Welcome back to Unleashing the Baseball Mindset. And we are here with Coach Dylan Gautreaux, myself, Dr. Kyle Stull, mental performance coach. And again, we have Dr. Jamie Rister. Jamie is an orthopedic surgeon. He works with a variety of high-level athletes. This is the second part of our conversation, talking specifically about injuries that we see in baseball athletes, talking a lot about some of the younger population, some of that youth population, those youth athletes. And we had a great conversation last week where we talked a little bit about orthopedic assessments, what some of the aches and pains might mean in your younger athletes. And today we hope to just expand on that. So one of the first things I want to start off with, Jamie, if you don't mind, last week, you talked a lot about internal rotation, and we talked a little bit about how there's posterior shoulder capsule. I think back in the day, we used to call that posterior capsular contracture, something like that. I don't know if that's a term that's still really used. And one of the tests that you do quite a bit is internal rotation. So I'm wondering, beyond that, what are other assessments that you might do, something to look, maybe more at the glenohumeral joint, or if you're looking scapular stability, if you look at the thoracic spine at all, if there's anything there that you might look at with some of these younger athletes that come in with either shoulder or elbow pain.
Yeah, so like you said, it's a full spectrum. I spend a lot of time first with rotation, and then we look for more concerning pathologies that may coexist with that. Look for any concerns for glenolabral, they call them slap tears in the shoulder. Make sure they don't have any signs of, true instability or pathologic, you know, slap tears, things like that. And the elbow, especially in the growing athlete, if they have any point tenderness over the growth plate itself, mixed with that internal rotation. Because if they do have any of those findings, I'm more quick to get an MRI or something like that to make sure that we don't need to be a little bit more aggressive with our treatment, as opposed to just fixing their mechanics and just fixing their recovery process. And so it's a little mixed picture. I usually start there, and then once we eliminate anything more concerning, then we start the treatment for the rotation of the shoulder, and then it does expound into hamstring flexibility, thoracic rotation. All that's involved in the same process.
Now, tell me about the point tenderness. So point tenderness in the elbow around the growth plate, and I don't think you necessarily want to use this to teach people how to do that. But when you're doing that, I don't really know where the growth plate is, so I'm assuming it's around the elbow there a little bit. What might that indicate if there is point tenderness there on the growth plate?
So as we're maturing, early on in the maturation process, our ligaments are very, very, very strong. And as we start to grow, those growth plates can become a little. I think we talked a little bit last week. It can become a little loose. And
Mhm.
if we see too much stress across the growth plate, we can get a little widening across those points of stress. And most specifically, most people are very familiar with the inside of the elbow with ligaments, the ulnar collateral ligament, Tommy John's, things like. It's always the word that most baseball players know. But where that ligament attaches in the developing athlete is the area of a growth plate called the medial epicondyle. And if an adolescent thrower has point tenderness over their medial epicondyle, it's very concerning that they have some inflammation or irritation of that growth plate. And typically, when they come in with true point tenderness at that, it's the most treatable thing that we see, because it almost always gets better. It's almost always gets better to, 100%. But if it's not recognized, it can get to the point where it starts having permanent widening that requires some type of fixation.
Okay,
I
and now
so Kyle, I want to jump in there real quick because remember we talked about this a few months back with two of my players that went to an ortho because of one of them was shoulder, one of them was elbow, and the orthos told them that they had growth plate inflammation. That's basically what they were diagnosed as, is growth plate inflammation. And for me, it's like, okay, well, why is that happening? Number one, they didn't have an answer for that. And then number two is like, is that an actual is that a diagnosis, Dr. Jamie? Like just growth plate inflammation? I mean, I guess it is in a way, sounds like from what you're saying, but isn't there more to that?
Yes, and that's how. So MRIs are somewhat confusing when you get them, and today everybody reads their own MRI reports, and MRI reports typically say inflammation noted along the physis, which means growth plates, or inflammation around the
Right.
medial epicondyle physis or proximal humerus growth plate. But the you're exactly right. It's not isolated. It's not one day that growth plate decided it's inflamed. It's some process has led to that growth plate becoming that way, and it's the stress across the growth plate that does it. It's the stress at the shoulder for somebody who's overloading the proximal humerus growth plate, or stress at the elbow for somebody who's maybe dropping down an arm slot, putting too much valgus overload. With another word that a lot of throwers know, a lot of valgus overload in the
The
elbow,
elbow.
which is now stressing the medial epicondyle growth plate. And when you get an MRI, it
Yeah.
is inflammation at the growth plate, but it's like what we talked about last week. If you shut that player down and say you need 6 weeks of rest, but you haven't addressed the other issues that caused it, then it comes back.
Is that usually a deceleration issue from what you've seen?
The deceleration issue that leads to the capsular contracture that you were just talking about a little while ago, the deceleration issue is typically what leads to the loss of internal rotation around the shoulder. The loss of internal rotation around the shoulder leads to an altered mechanics with throwing. So usually I tell my athletes to compensate for the loss of internal rotation, you either have to elevate your scapula a little bit, come over the top, which leads to shoulder stress, impingement, proximal humerus pathology, or you have to drop down an arm slot, which leads to valgus, pressure around the elbow. It still comes back to a lot of that, loss of rotation around the shoulder, but that overloads the joint that they choose to compensate with.
So what you're saying in essence, the lack of the internal external rotation is a precursor to all that.
I believe so.
I see is a lot of these kids are leading with their elbow too soon. So they're getting the lay back too soon and then arm dragging and then coming through after, the way after the hips have already come through and then they're dragging the arm around. Are you saying like that's usually the case with that situation?
Yeah, and that brings back another. It's not 100% loss of internal rotation. That's the problem. I had a person in my clinic today that probably one of my most difficult patients to take care of is the shortstop or the second baseman that also pitches, because
Right,
they
right,
love
right.
they love to throw off balance. It's the cool thing to do. They love to throw with that arm down and lead with the
Absolutely.
elbow. And then that
Yep.
transitions to a pitching mechanic that is a little bit different to deal with. That may be a little bit outside of what we were talking about with the shoulder internal rotation. That's more of a purely mechanic problem that causes that valgus overload. But I see that
Yeah.
a lot in my middle infielders that also pitch.
That's one of the hard thing with coaching because I coach my pitchers, right? So I'm the bullpen coach, and that's one of the hardest things. You're absolutely on point with that. Is that your shortstop, sometimes third base, depending on how many double plays they're turning, they're coming across their body, and usually because of the way that they're setting up their body, which is the right way to set up the body, but then they're coming through and they're leading with that elbow and coming across. And then you get them on the mound, tend to do the same thing. So they can't differentiate those two.
That's one of the reasons why when we're in the recovery phase and of one of these pathologies or working on mechanics, that's why even in practice I encourage my kids to, even if they're turning a double play, even though it's not as cool, I always make them take a crow hop and face where they're throwing.
Well, let's talk a little bit more about treatment options, which is something you alluded to a little bit earlier. So you have a young athlete comes in, and let's say they're between the ages of 10 to 13, maybe 10 to 15, and you identify some of these concerns. What is your recommended treatment approach? What do you start with? What do you progress to? And what is it you're looking for in those treatments?
So in the elbow, it's pretty. We'll start with the elbow first. So if somebody comes in with medial elbow pain, first we test for tenderness around the growth plate. Yeah, the medial, the
Yep.
inside of the elbow. So if somebody comes in with medial elbow pain, typically the first thing I do is test for point tenderness, either around the growth plate or around the ligament, which attaches in a very short area right next to it. And I also test for irritation of the ulnar nerve, which runs directly behind the medial epicondyle. And with irritation of the ulnar nerve, you can get some tingling into the ring and pinky finger of that throwing hand. So we start by differentiating point tenderness around the growth plate versus ulnar nerve irritation versus true instability with ligament involvement. What helps with that is, and like we talked about last week, you can't ever assume somebody is growing without taking an X-ray because you have to be able to see the growth plate. If I have a 15-year-old baseball player who has a growth plate that is closed, then we're thinking about different pathologies, different mechanism of injury. If the growth plate's open, then we go down a separate pathway. So in the athlete that has an open growth plate, which means they're still in the growing process and they have tenderness along the medial elbow, I shut them down, start working on rotation at the shoulder, and I see them back in about 2 weeks. And once they have no tenderness at the elbow, which is usually about 2 weeks, 2 to 3 weeks, they usually recover pretty quickly. Then we start working on the therapy side of the process, more pronator strengthening, shoulder rotation, and then usually by the 4 to 6 week, we get them back into a throwing program and kind of ramp them up pretty quickly. If it's a patient that has a closed growth plate with medial elbow pain, I have a much quicker threshold to get an MRI. So we want to look at the ligament.
Yeah, yeah.
Let me ask the all right. So back to the open growth plate. You said you shut them down. So that means stop pitching completely. Are they able to throw at all? And I'm not the baseball player. I played t-ball until I was 7. I hit one home run and then I retired. So I went out on top. Yeah, I I don't understand why that's so funny to you, Dylan. Why do you have to laugh at my
Show us
accomplishment?
your trophy. Show us your trophy.
I don't know where it is. I think my son. 'Cause it fits right in with his trophies. But so you shut them down. No pitching. Can they throw at all? Or are they off the baseball field? What does it look like for you? And you said they work on rotation, so just some flexibility stuff? Or
So I have a it's not my literature, but I have a very generic, it's called a thrower's 10 packet, which goes over the basics of health around the shoulder. It's something that I found quick and easy. I give the patient a packet of information on what exercises are good to do. I show them sleeper stretches to work on posterior, flexibility. I find it such a gray area. I started out saying if you're first base, you can play first base, or in the travel ball world, they're like, "Hey, can I play first base?" And it's so gray because if you're truly trying to recover from an injury and get back at a rapid speed, any assault on that growth plate just sets you back. And it's hard to tell a kid who's playing first base and you have a runner going to third not to throw it to third. And so
Yeah, yeah.
I've transitioned to if you're a right-handed thrower and a right-handed batter, I don't let you throw or hit because swinging a bat from the right side still puts valgus stress on your elbow, and all it takes
Yep,
is one bad
yep.
swing to keep the process going. So I shut them down from everything. Now, sometimes I'll be a little bit more lenient if you're a right-handed thrower or a left-handed batter, because it's less stress across the elbow. But I usually have a very pointed conversation with the athlete and the family just to say, look, if you're not better in 6 weeks, we don't want to say it's because we've been doing too much. We want to truly know if we've given it the best shot we can. Because the plan Bs and plan Cs from this are usually not very good.
and you said that you see them back in 2 weeks. So if they do completely shut it down, it sounds like it might be a relatively quick recovery. Not saying that they'll be 100% within 2 weeks, but they should see some improvement within that short period of time.
Yes, and absolutely. And it's very important for your athletic community to follow them closely because if you tell someone you have an ankle sprain, I'll see you in 6 weeks. I mean, nobody wants to wait 6 weeks to do anything. If you have a patient who's throwing a ball and you see them back in 2 weeks and we can follow that closely and they trust you that you're truly trying to get them back as quickly as possible, usually have a little bit more buy-in than "Hey, I'll see you in a month or two. Just take it easy."
Yeah, yeah, I
And
like
Dylan
that.
really likes to ice everything. So what are your opinions on
No,
24 hours a
that's
day
not
just
true.
in
That's not
in that
true.
matter?
Like, I love ice.
Ice heats. Go ahead.
Yeah, I love ice in the early process, in the inflammatory process. I love ice. I mean, I think it works great, but I mean, it doesn't prevent an injury, but I think it really helps with the inflammation and the swelling around an acute injury, something that's happened within the first 2 to 4 weeks.
So do you not believe in the reversing of the lymphatic flow that ice will do? That, like the recent studies, I forget his name. Do you remember his name? The de-ice guy, Kyle? You don't remember his name? So he did a bunch of research on or MLB, tennis players, NBA, I think hockey. And essentially his goal was to get ice out of every locker room. Other than bleeding that we couldn't stop, or compartment syndrome, things like that, in order to speed up the lymphatic flow to go straight into heat and compression versus the ice situation. And the whole idea behind it is, with the ice, it tends to reverse the lymphatic flow. So then as it's trying to heal, then you're having to come back in with the lymphatic flow in order to get rid of all that, coagulated blood or whatever it is, to push that back out and then come back in with new blood. So his idea was that it was taking too long to heal with ice versus no ice.
Yeah, and I think you have to look. I'd have to look more into that, but I think it matters ice with compression or ice without compression. I think that makes a difference. There's a lot of the icing opportunities these days, all have some type of compressive form with it that helps with the lymphatic portion of that. I'm also a fan of early motion, and I believe motion
Yeah.
is
Yeah.
one of the most important things with lymphatic flow. If you ice and immobilize, I think that's pointless.
Yeah. No, we
Is
we agree on that for sure.
well,
His idea was more of like, he's got a book called De-iced, and essentially it's the movement starts immediately, like without extreme pain, of course. Movement starts immediately
Mhm.
using a Mark Pro device and getting away from the ice completely, because in essence, the whole reason why the ice thing started was because of it makes the pain go away. Essentially, you're numbing the area so pain goes away, and that it doesn't help with the actual inflammation process. It actually backs it up. So it's not allowing for that lymph flow to come through.
Look, I've learned one thing in my short 10 years of doing this is that, and I learned this. I used to go to the X Games once a year, pre-COVID. So 16 through 20, I went to the X Games for 4 years, and I would get to go into the athletic tent. And in the athletic tent, you had the latest and greatest device, be it, I remember when suction cups came out. I remember when the Theragun came out, and they were giving them away like Skittles to all the athletes. And then it followed like clockwork. 6 months to a year later, everybody had suction cup marks on their back. And then a year later after that, everybody was putting a Theragun everywhere you could. And I believe they work, and I believe they're good in for certain instances. And just like ice, and just like compression and early motion, and I think that's where some of our parents and some of our coaches kind of get off track. Is one modality never works for everybody. It's some combination of this. And as long as you're open minded, probably the most common question I get asked these days is, "Doc, are you okay with peptides? Are you okay with, a blue laser or a red laser, 10X?" They're all modalities that you can use. And I think they do have some benefit. It's just a matter of pinpointing that modality to what we're trying to accomplish.
Yeah, and I always supported the icing, to Dylan's point about the pain. Well, if mitigating the pain leads to earlier motion, that's a good thing. And but to your point, one modality doesn't, it's not going to work for everything. Also, really, I think it's worth pointing out the placebo effect. The placebo effect is a very real effect. So if you think it's going to help, if you truly believe it's going to help, it's probably going to help. You might want to be careful with how much of it you use, no matter what it is, but it might be beneficial. And talking on the early motion, so going back to growth plate concerns, if you shut somebody down for a couple of weeks, Do you ever have athletes that think, well, okay, that means that I just need to not move, or what is your instruction there? You want them still using their arm. You want to try to avoid some of that valgus stress, but beyond that, do you try to change anything they're doing throughout their daily life as far as lifting or using the arm?
Yeah, so I mean, and again, this is you got to pinpoint this to each individual person, but my young kids, even as far as you have to give them examples that nobody thinks about, even carrying your backpack on your shoulder like this all day long and putting a valgus stress. I mean, things
Yeah.
that people don't think about. But I typically, I start out the first visit with, stretching across the forearm, kind of wrist extension, wrist flexion, making sure our pronators and supinators are flexible. We start stretching those day one. Sleeper stretch is almost always day one. Motion is, crucial to the first visit. I think we talked about this last week. I tell everybody if we're taking a break, we're taking a break to get better, not just to rest. And so we start working at it from the very first day on some type of exercise. I give them, I give handouts in my clinic, you know, to just about every patient that comes in and make sure that we are doing some type of mobility and not just resting.
What are you looking for a forearm? Do you do so? If you're looking for range of motion, what are you looking for? Are you looking for wrist extension to a certain degree, wrist flexion to a certain degree, or just seeing how it moves?
I'm not really, I don't look at a lot of motion at the wrist, and I probably should do more of that, but it's more or less most of your forearm pronators are attached at the medial elbow, your flexors. And that's usually the area of concern when they come in with medial elbow pain. So anything can cause stress there, not just the ligaments, not just the valgus, but even if they're starting to get a little medial epicondylitis or anything like that. So I start with stretching of that the first day in addition to the shoulder work that we go with. But almost universally, everybody starts stretching their form. If you're a thrower, we start that day one.
And real quick, anatomy lesson for anybody listening. The way I teach this to undergraduate students is whenever your palms are rotated up, you're able to hold your soup so that is supinated. If you rotate your palms down, you are prone to drop your soup, so that is pronated. And so the
I think
muscles that
I think that's
do that.
exactly how we learned it in med school too.
Good. Perfect. Perfect.
Hey, you know what they taught us in Southern Louisiana? I'm not going to say it on the podcast, but remember I told you about the supinated, how we learned it?
No.
No, all right. I don't want to say it on the podcast because it's kind of
All right. Great.
it's yeah, yeah.
And another question related to that, Jamie, is you talked about that sleeper stretch, and last week you had mentioned too, you really have to make sure to stabilize the scapula. I've always had a tough time teaching people how to do that. If I'm ever assessing it, I can do certain things to make sure the scapula is stable and in a position that I want it. But as far as stretching it, as you know, like people will do some crazy things. How do you teach a young athlete to try to stabilize their scapula so that way they can actually stretch the right part of the shoulder? Or do you think, well, doing something's better than nothing, so it might not be perfect, but still work on it?
I mean, my cheap way to do it is, I learned this in the rotator cuff world with my older patients because they do it worse than anybody. If you have a damaged rotator cuff, you're going to elevate your scapula from the get go, and it's very difficult in those patients to convince. So, I mean, I make them I make them sit 90 degrees against the wall. I make them physically touch a wall when they're doing it. And it's a lot more difficult to elevate. Yeah, it's a lot more difficult if you're against a wall at 90 degrees with your back against the wall.
Gotcha.
It's a lot more difficult to get here and protract that scapula if you're actually touching something.
Okay.
Yeah. Yeah. I like that.
Well, let's go beyond that. All right. So you have somebody, you give them a few stretches, you have them take some time off. Let's say that doesn't necessarily work. Is there what's the next level of treatment? Is this whenever maybe you do more imaging? Would you ever go to injections with a young athlete, or what would be the next step?
So growth plate open, if they're 2 to 4 weeks still with pain at the elbow, MRI. I typically get it to confirm we are going down the correct pathway or not. People with closed growth plates, so your 15, 16, 17-year-old guys, usually the MRI has already been done at that point. And if there's any inflammation or irritation around the ligament itself, either at either attachment, so it attaches on the humerus bone and the ulna bone on the bottom side. And so if there's any inflammation around there, I have a conversation from the very beginning on a possible PRP injection. I've had a lot of success recently with PRP injections in the skeletally mature athlete with medial elbow pain and MRI that does show some irritation around their ulnar collateral ligament. And we treat it from that point forward, we treat it the exact same, but I'm much more aggressive in the skeletally mature athlete to add a biological approach to it as well.
Okay, and PRP, enriched plasma, is that right?
Correct. And there's
Okay, and is
and
that
it
something? Yeah.
and it comes in a lot of different varieties. I mean, there's as many different types of PRP these days as there are, flavors of candy. But, something that helps with the stimulation of healing around that ligament to get the PRP into the damaged tissue, usually under ultrasound or some form of that, to make sure that we're trying to give it every chance it can to heal. Because the conversation we're having with these athletes and the parents is that if this doesn't heal, then we're talking about, you know, a repair or a reconstruction, which again is always last resort.
Yeah.
Mhm.
And are you
And
staying away from steroid injections, cortisol injections, cortisol?
I don't do it at the elbow,
Good.
especially. Yeah,
I love to hear it.
I mean, the only time I've ever done that is for the 22-year-old guy that's got one game left and he's never playing again, has
Yeah.
no aspirations of
Yep.
anything further. Maybe we'll help him out, but we lay. I have a long conversation on risk of that as well.
Yeah. Yep.
Anybody that's got potential of progressing, we don't do that. I don't do that.
I love to hear that. That's it's still such a common practice, which is crazy to me. Giving it to him often.
well, I'm just curious, like what, and we don't have to get into a lot of details here, but is it just is it deterioration of the tissue? Is that why we want to stay away from that, and why you stay away from it unless it's the very end of someone's career, or is there something else to it?
Well, it does help with the inflammatory response, but the main thing it does is it helps with pain, which is good, which is it seems advantageous. But if you have a true injury and you haven't fixed the mechanical problem of it, but you've suddenly allowed this athlete to now do what was wrong, but without pain, almost universally it gets worse. And then now we're taking something that was very manageable without surgery, turning it into a potential surgical issue.
Yep.
Point. And I
That's
always
good.
like to say that there's a reason why pain hurts. It means
Right.
that you need to stop whatever you're doing, or change something, not just mitigating or reducing the pain. And now, if we're looking at PRP injection, what is the athlete usually doing in their own time? Do you get them connected with a physical therapist or some other type of a practitioner that they're working with? Or is this still just kind of like seeing how it goes with them just taking some time off and doing a few stretches?
Well, so unfortunately, I get to see them at usually very scheduled visits, usually 2 weeks, 6 weeks. If I bring them back early, 1 week, 4 weeks. But it's still very limited in their recovery process. So I have a few therapists that are local that over the years we've developed a close relationship and a passion for throwing athletes. And so I have two or three guys that I try to get them in with to start working from the very get-go, from in my skeletally immature people with point tenderness, I get them in as soon as they no longer hurt. And for the people who are skeletally mature, I usually get them in the first day, just so they can start working under somebody who's supervising them and checking in with them more routinely, and somebody who's frankly more hands-on, because a lot of these athletes need that guidance to be able to recover at the speed we want them to.
Jamie, something else I wanted to ask, and we've talked about this on the show, and I have certain theories about development from a kid all the way up, especially for about the first decade of life. But one of the things we've talked about with throwing athletes is kids these days don't seem to grow up doing as much hanging and climbing and those types of activities. My son, he goes to a ninja gym. So he spends a good part of his Thursdays swinging from rings and climbing things and doing that. And I'm just curious, what are your thoughts on those types of activities very early in life? Do you think they would improve shoulder health, scapular stability, or do you think whenever it comes to throwing and the increased competition and the desire to throw harder and faster, maybe those types of things as a kid don't matter as much as they used to? Any thoughts on that?
Yeah, it's quite funny you asked that. I had that conversation, I think, 3 times today with lower extremity involvement. In the athletic world, we've gotten very good at making people bigger, stronger, faster, throw harder, and a lot of the strength and conditioning environment in the lower extremity, the quadricep muscle has gotten so exponentially stronger to get you quicker, to get you faster, to make you jump higher, and but a lot of a lot of the attention is around a single muscle group because you get the biggest bang for your buck. If you go into the throwing world with velo and everything, they have you doing everything you can to build up the anterior part of the shoulder, your chest muscles, to get the most bang for your buck. And what happens is you start getting these compensatory pains and problems. Um, where we used to never see it. That was the conversation I had earlier today. When I was playing ball growing up, we got out and ran. You ran hundreds, you ran 50s, you ran up and down the field, you ran poles. There was a lot of outside conditioning that led to a little bit more balance. Everybody in the today's in a gym, box jumps, leg press, squats, everything you can imagine in a gym for throwers, focusing on increasing internal rotation strength. I don't remember doing that growing up. And the conversation I was having today was based around ACL injuries. When I was playing football all the way through college, I can name the people who had ACL tears. I
Yep.
didn't know a lot
Yep.
of them. And I have 3 or 4 photos on my phone of 5 kids from one team on separate years that all have ACL tears. And it can't be just, it is what it is. There has to be a reason behind it. And I think it's that we've gotten so good at making people bigger, stronger, faster, throw harder, sometimes to their detriment.
I think that's a great point. And on that, the ACL too, I've talked about this quite a bit with those. The ligaments help to provide stability to the knee. And ligaments, just like everything else, it will adapt to stresses that are placed on them as long as there's time for recovery in between that. So as a kid, whenever you're getting this rapid growth and strengthening of muscles and tendons and ligaments, if you're out in God's world, going up and down hills, if you're running across tree roots, if you're doing these things that provide these little micro stresses to the ankle, to the knee, to everything else, it develops up to be a much more robust joint in combination with developing more hip strength and core strength and this other stuff because you're like out in the world. And if you're on a manicured flat field all the time, from the time you can walk until the time you're whatever, you just don't get the same stresses. The body doesn't develop to be quite the same. And I think it's the same for the shoulder too. If you're out there doing stuff, I mean, Nolan Ryan installing air conditioners from the time he was 6 until 49 or whatever.
Just the lack of cross training in general, whether it be playing outside or playing other sports, they're not training in different environments. Like you said, there's no terrain. These guys complain if there's one pothole in the field, and it's like, man, that's how you get better at movement patterns. That's how you get better at reaction, is having divots in the field, having a rough infield, outfield, all that kind of stuff. Like when we played ball, we didn't play on turf until I got into college. So it was all grass and nothing was well manicured. And then in the off season, we were playing in the yards. We were, like you said, climbing. We were falling down, getting back up. But a lot of these kids aren't doing that anymore. So it's unfortunate.
And another thing that has come up in some conversations talking about being able to transfer forces from the ground up through the body and be able to express that power into the upper extremities. And I think again, kids just don't seem to be to be getting that. And we've talked a little bit about kids playing and horseplay and wrestling and maybe even fighting. My son's really into WWE, which is not a very good example. But watching whenever he tries to wrestle with his friends and they kind of grapple for a minute, they'll grab each other and they dig in with their feet. And as a 6-year-old, he's learning how to use the force from the ground. And it will make him a better ball player if he does it enough. And I think that's another thing where I forget who we talked to, Dylan, but he was talking about kids get into high school and then they're just learning that, well, man, they can't generate the force for whatever reason. They're just not able to do it. And learning that as a kid by being out, doing things. And I wish more people would understand that. Get your kid outside to learn how to use his body and develop that stability and strength.
And just to piggyback on that, you're exactly right. In the lower extremity, as much time as I spend on the upper extremity talking about the posterior shoulder, in the lower extremity, I spend equal amount of time talking about hamstrings. The hamstrings are the neglected body part of the lower extremity. Hamstring flexibility, hamstring strength, and it's not just in people with lower extremity injuries. People with upper extremity movement pattern disorders, typically have a loss of motion across their hamstrings, which directly affects how they plant when they go to pitch, how they step when they go to throw. So they're all interconnected.
Let's say you have a right-handed pitcher. Do you ever notice more problems on their left side of the lower extremity? So maybe more left hamstring, left glute. So kind of that contralateral type of a movement pattern where you see problems?
I don't have any scientific data to back this up, so this is just my observation, but I tend to find that whatever arm that you're dominant with, you have more problems with the contralateral lower extremity. So right hand dominant typically have more left knee problems. Left hand dominant tend to have more right knee problems or right lower extremity problems. And I believe that's because you're a little bit more dominant on that on your contralateral legs. Snowboarding, for instance, regular snowboarding, the term regular means left foot forward. So you're going down a mountain with your left foot forward. Goofy, which is the goofy version of it, you're going down right foot forward. And so I think it's natural that the contralateral leg is typically where I see most of the issues.
Yeah. Looking at any sort of an overhead athlete, like it is oftentimes, we talked about deceleration. Well, as this arm's coming forward, you have that lat on the right side. That has a really strong connection with the opposite side hip. So that left side glute, left side hamstring. And so a lot of that deceleration will come from that stance leg, that opposite side leg as well. So it's kind of the same. If you're not getting that function from that left side hamstring and glute, then you might not be able to stabilize that right side scapula quite the way you should. And you might start to, compensate there or see something show up and a lack of internal rotation over time or something to that effect. So I always found it interesting too to check those opposite sides, really in everybody. You get somebody, and I'm not a surgeon, obviously, my medical training is limited, but you get somebody that has a right side shoulder injury, they're not an athlete. There's no apparent reason why it would hurt. A lot of times you can track that back to something going on the left side, whether it's a hip, knee, foot, or something like that.
I don't know if you have any experience with the actual training that goes on, the strength and conditioning training that goes on in baseball when it does happen? Like, we're doing it at an earlier stage than most, but what does it look like? What does that game plan look like for you? If you had any advice on how to train and how to map it out. Right now, we have a 13-week cycle that we're doing that we're trying to push it into a macro cycle, like through the year, of course. But right now we have 13 weeks during the fall that we will be training. I wanted to know, like, what would yours look like? Like, let's say you're looking at a training during the fall. What would yours look like? And we're talking,
Well, and
let me just ask you for pitchers, for throwers.
well, and that's a great question because I think that's why these conversations that we're having over these podcasts are so vitally important because the relationship between athlete, coach, trainer, doctor has been always very separated. You go see a doctor to get pulled from sport. And that's the kind of stigma that, a lot of the surgeons have, or a lot of the people who try to manage things conservatively is don't send me to the doctor. If you send me to the doctor, I'm going to have to sit out. And so a lot
Right.
of that falls back to the trainers and to the strength and conditioning coaches. And so you have a lot of people involved in any one athlete's care. Where I find the most success with what you're asking is for the people that I've been able to build relationships with, the head coaches, the head trainers, to where they no longer feel threatened to say, "Hey, I'm going to send Johnny to come see you. I just need an opinion. What do you think?" As opposed to, "I'm going to send Johnny to you because I'm not gonna send him to you because you're just gonna pull him and I can't have him for 6 weeks." And so it
Right.
was always it's been a give take, but I think that's why these conversations are so important because I think everybody has something to add from this. I don't think any one person is more important. I think that, the education that I've gained through taking care of these athletes, and a lot of this education has been through not just what I've learned in residency and medical school and from other doctors. It's equally as important what I've learned from athletic trainers, physical therapists, and coaches on how to relate and how to be involved in this process. But a recovery process, a 13-week process, involves in first evaluating what the needs are. You have to say, you look, I have out of these 13 kids, I have 10 of them that are starting to alter their mechanics because of shoulder issues or elbow issues, or they're doing it. They pitched for an entire season. So in the off season, we don't want them pitching. We want them working on, fundamentals from movement mechanics. And we want them to really focus on posterior shoulder strengthening and flexibility. We wanted to work on forearm pronation. We want hip rotation, hamstring flexibility. These are the deficits that a pitcher gets from throwing for an entire season. So these 13 weeks, we're going to spend not on pitching. We'll still go through that, but we're going to spend our time on what we've developed as deficits from being a one position athlete.
I think that's a great point. And with that, too, it sounds like you're recommending an individual approach. So you have 13 athletes. Well, it could be 13 different approaches. A lot of times they do kind of funnel into the similar buckets, but individual assessments. So that way you're giving them what that person needs based on their growth, based on their deficits, based on whatever it is they need to work on. Is that right? And I guess the reason I ask that too is because all too often we just kind of say, like, all right, all 13 of you guys are going to go do this.
That's what happens in most high school programs, much
Right.
less 13. Like my kids, right, they started training early on as far as like movements with just squats and lunges with twist and rotational movements with the lead leg block and all this stuff. My kids started at a very early age. But what you're seeing in the high school programs, it's usually the football coach who's coaching them, and they're going in and they're doing bench press and deadlift and squats. I mean, I see it every single day with the performance course. The performance course, Dr. Jamie, is a very big organization that basically takes over every high school in DFW, and they go in and they just train the masses. And essentially what they do is they have high school kids watching over this, and you have to do it in order to play high school ball. You have to do it: football, baseball, basketball, track. And even my son goes to a little bitty Christian school, and they're doing performance course. And I had to have a talk with the coach and let him know, like, he's not doing this, he's not doing this, he's not doing this. However, he can do it with dumbbells, he can do it with kettlebell, whatever. There's certain things like a deadlift from the ground with a barbell. To me personally, unless you're a power lifter, no reason to do it. Now, like rack pulls and things like that, I'm cool with. But pulling a deadlift, a barbell from the ground, I don't want my son doing that, especially as a pitcher and a catcher. Now, with a hex bar, getting more muscle tissue involved, I'm perfectly fine with. But there were certain things that I had to talk to the coach about, like Max is not doing this. And the performance course is, again, it's run by former performance course kids that are maybe in college now, and they go and they work this performance course and they run it through the masses. They're not really working on technique. They're not working on anything other than maybe 4 to 5 basic lifts that they're doing. And they're all running through this and all of DFW. And for me, I'm having a lot of times mitigate the injuries that have happened during the performance course. That's what's happening in most of the high schools around here. They don't have a good strength training coach. and they don't understand, rotation, stopping rotation, deceleration. They don't understand any of that.
Well, a good example that most everybody can relate to, I see it routinely in the football world. So an offensive lineman, a defensive lineman is coming out of a stance almost every play, and they do this over and over and over again. So the stress they're getting across their knee, patella tendon, kneecap area is more than any other position on the field because they're coming out of a squatted stance and firing off the ball to play their position. But they still do the exact same strength and conditioning program as the wide receivers. They're still doing box jumps, they're
Yeah.
still doing front squats and everything else. It's a uniform workout. So two of my high schools that I work with closely here, I can politely convince the schools to get leg press machines because leg press machines are much less invasive on the patellofemoral joint, especially in these athletes who start at an early age getting patella tendonitis, kneecap pain, which is almost uniformly in down linemen. So that's a small example of there's no way, shape, or form a down lineman should have the same strength and conditioning program as a wide receiver.
Yeah. Or a baseball player. That's
Absolutely, absolutely. Even with I say
that's what we're seeing. It's usually the football coaches in most of the high schools that are coaching the strength and conditioning program. And it's just like you said, man, it's insane.
It's unfortunate too with the size that sports are. The size is that
Yeah.
especially high school
Yeah.
sports, like here in Texas, high school football. But it really just boils down to there's a lot of kids playing and there's not that many people to coach them. So they can't always do the individualized assessments. They can't do this or that. I still think to y'all's points, there's better ways you can do it.
Yeah.
And I'm not sure if people are just not receptive to that or what the case may be.
A lot of times it's just like coaching baseball, and I'm talking about the X's and O's of baseball. A lot of times these kids just don't want to learn more. They just want to use what they have. And I've seen multiple professional baseball players that just can't coach baseball because they relied on their talent. They did what they were told, but they never learned anything as far as how to coach. And that's what we see all the time. It's like most coaches are not willing to keep studying the game and looking at the new things that may be better than what the olden day, what we did in the olden days. And again, like we said earlier, it was a little bit easier back then because we were all playing outside. We were all like, I was jumping in, marshes and jumping in bayous and all that kind of stuff. And so the terrain was completely different that we were dealing with. So maybe I didn't have to work on rotational and getting up out of a stance and different things like that, where these kids need to work on it. However, the coaches aren't willing to learn what they need to do that.
There's also the flip side of that. A lot of the schools that I take care of in Central Louisiana, I never doubt the coach's desire to do it. They just don't have the capability to do it because they don't have the resources, they don't have the time, they don't have the assistant staff like some of the larger schools. I take care of a lot of smaller high schools where the coach is eager to know what to do. It's just nobody's helping them understand it. And so I think there's also the benefit of having conversations like this. I think there's a large population of people. I mean, I had a coach from a local high school today in town asked me the exact questions we talked about last week on the podcast. And as we were going through the conversation, he was asking about he was here to see me for himself, but he was asking about one of his athletes. And I asked him, I said, "Have you seen the podcast?" And he goes, "What podcast?" And I said, "Well, I gave him the information on it." And he was like, "Look, I'm gonna listen to that today." And I was like, it's very beneficial for the people who just don't have the resources. They need a little help.
Yeah,
And
I agree.
you need to mandate that all of your athletes and all of the people in high school listen, subscribe to the podcast.
This is part of your program. Put it on the exercise sheet.
Yeah,
Right.
yes. Mandate.
I do want to expand on one thing that I said last week that I didn't get to, clarify very much. And to kind of goes to the point where what I said earlier, it's almost universally when a coach's kid comes into my clinic with a problem, they're usually the most receptive and the most eager to work to do whatever we need to do to get them better. And what it shows me is that the coaches want to be involved. They want to do what's right. It's just that they don't have, like it goes back to earlier, they don't have the the time, the energy, the information to do this with every single athlete. I think that's where we get more successful with this is education, 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 because when they come in and listen to it, they believe they run with it and then they apply it to their other athletes on the field. But until it hits home, it's just very difficult because they're relying on a kid to come back from a doctor's office or from a therapy visit and they just say sit out 6 weeks. And if it's never explained why, what we're working on, what the goal is, how we're going to get this athlete back to you, it gets to be brushed off a little bit. But the more we can educate, I think is will be much more receptive.
What is the best way to educate the youth athlete parent? One of the reasons we did this is because we want to try to get some of this information out. But of course, we can only reach so many people unless we grow. But more locally, smaller communities, what's the best way for Dylan to educate his parents or to educate other teams? Is it just pamphlets? Is it handouts? Is it just
They're not
talking to
reading the handouts. They're not reading the
Yeah.
handouts.
It's tough. I mean, we've gone through every thought process to try to get that happen. Give every coach a free bar tab one night, get them together so we can talk about it to to have, a meeting where if you can it's like a Q&A where you can ask questions. But no, I mean, I think the only way this is successful is through relationships. Um, and it starts at the very bottom to the very top. Whoever's on the top, whoever's on the bottom. It's relationships with the providers, with the trainers, with the strength and conditioning coach, and with the athletes and their families. But the only way this is successful is that if you have a therapist who thinks that they're the best therapist in the world, and the only way you're going to get better is by doing physical therapy, or if you have a physician who thinks that the only way a athlete's going to get better is if you come see me and we fix it surgically, or if you have a coach, you can see where I'm going with this, but until everybody works together and builds the relationship across multiple disciplines, across multiple modalities. And I think that's where we got into a hole in the past is that everybody was not afraid to ask for help, but everybody wanted to kind of do this separately instead of all together. And I think that that's changed. And the more we build a relationship with all the providers and coaches, I think we'll be much better at this.
I think that's really key. And to something you said earlier, why people might not want to go see a surgeon. Well, the stigma is that surgeons want to do surgery. A strength and conditioning coach wants to make you lift weights. And it's unusual to go talk to a surgeon and them not want to do surgery. I'm sure there's a lot of them out there. But like what you were talking about, I've heard zero stories of you doing surgery on anyone. It's all been other approaches to care because they don't need surgery just yet. So I think you got to find the right physician to talk to. You got to find the right strength conditioning coach. And again, building those relationships and having those conversations is key.
I tell the parents all the time that go to a surgeon that tells them to take 6 weeks off or whatever, and they don't give them, go see another surgeon. Go find a surgeon that's willing to work with your kid or at least give them somebody to work with. Dr. Jamie is doing the exact right thing. Is that what we need in youth sports? Obviously it goes beyond that. But for me personally, from selfishly, youth sports, man, it's just a mess right now with all this stuff. I've had multiple situations where the parents go to surgeon tells them this, that's what they do. And then the kid never gets better. And it's a shame that we don't have more surgeons like Dr. Jamie, but I think it's exactly what he said is like getting us all on the same page, making sure that we are all listening to each other. So when are you opening in DFW?
I do have several good friends in DFW.
Maybe you just need to get one of those RVs and outfit it with a little
There you
area
go.
to do surgery
There
or
you go.
whatever. And then you
Yeah.
just drive it over. Cash payments only.
A mobile
Cash
surgeon.
payments.
How about that? Mobile surgeon.
There you go.
I like it.
All right. Well, guys, thank you so much for your time again. Jamie, it's a wonderful conversation. One of the things I like the most about this podcast is getting to meet people like you. So this has really been a pleasure, and I'm sure we'll have more conversations in the future. So again, I thank you so much for your time, and I hope you'll have a great rest of your day.
Thank you.
Thanks, buddy.